So, when you're talking about premature infants, they are ready to start taking food by mouth or trying to take food by mouth when they are medically stable, when they have the appropriate posture control, when they have appropriate respiratory ability, so an even oxygen saturation of at least 95%. They need to be able to reach the appropriate level of arousal. They need to be able to display a non-nutritive suck pattern before transitioning into the nutritive suck pattern. And for preemies, this usually starts around 33 to 34 weeks. Prior to 32 weeks, they're generally not ready. So generally speaking, some of the things that we do for these babies, we get them on feeding schedules. We educate the caregivers on how best to feed the babies. We work with the babies to reduce their oral aversion to feeding. We use oral stimulation to increase appropriate sucking and suckling behavior. We do our best to establish that non-nutritive suck that they need to get before moving to PO intake with the nutritive suck. And as already mentioned, you want to do everything you can for that baby to make the experience, the feeding experience, a pleasurable experience and not a negative experience, or they will not do it. So we play a role in altering the environment. If the child's level of arousal needs to be decreased for optimal feeding, we may dim the lights. If their level of arousal needs to be increased, then we may have more lights present. We may swaddle the child, which means wrap them up in their blanket really tight to keep their arms and legs from going places, so that they are able to focus more on what's going on here. You want to watch for signs of distress as the child is feeding. And you want to be aware of what that child's optimal position for taking food might be. We also alter the nipples in the bottles to accommodate certain babies and their needs. We pace the feeding appropriately. Sometimes these babies can have really tight diaper straps. So too tight a diaper strap is going to cause reflux. So being sure to go in and loosen those diapers. If the child has a G-tube, then once PO intake begins to be introduced, they're probably not going to just be able to go from full feeding tube reliancy to full PO intake reliancy. So you're going to have to start alternating oral feedings. And it'll generally probably start with the baby having pleasure feedings. And then once they get better at taking that food, then increasing that to actual meals. Distress signals in a very young infant can be very subtle, so you have to keep a sharp eye on them. Sighing, yawning, sneezing, sweating, obviously, is a distress sign. Too much hiccuping, trembling, too much startling, facial grimaces. If the baby is falling asleep, then that may be them trying to get away from the feeding. Squirming away from the bottle, not looking at the bottle. Straining, and you'll feel their body strain and tense up, which may be indicative of a bowel movement. If you notice that they have to take multiple swallows per sip, then that can be a sign of problems. Obviously, increased hyper or hypotonicity in the child as they're feeding can be indicative of a problem. Signs of major and more acute distress in the infant during feeding is obviously that child coughing or choking, spitting up too often, gagging. Changing color is a bad thing, right? So if the child gets too blue or gets too red, if they're not breathing often enough, if their respiration is not regular enough. And as already mentioned, you have to monitor their respiration to be sure that they're breathing appropriately. You have to monitor their O2 sat to be sure that that respiration is being effective. Bradycardia means decreased heart rate. If the heart rate goes too low, obviously that's a problem because that can mean not enough oxygen getting out to the body. And the arcing of the back is something that babies do when they are trying to get out of a situation. We generally grade an infant's level of alertness on 6 different levels, with 3, 4, and 5 being the sort of in-between ones that are appropriate for feeding, although it does vary by child. But closer to 1 is more sleepy, closer to 6 is more agitated and crying. So 3, a drowsy, a semi-dozing baby. You'll see this as some babies feed. They oftentimes start more alert, but once that milk starts getting into them, their eyes will sort of roll back in their head, but they keep feeding. Level 4, quiet alertness. Child is sitting there feeding, and their eyes are clearly alert, and they're probably looking at something, and they may be looking at the person feeding them. Number 5 is baby is being more fussy, but is still taking food. Above that, you go from fussy to infant crying, and that's where you don't want to be during a feed. So to help a child increase their endurance during the feed, you want to be sure that baby is in the most effective postural position so that they're not spending a lot of energy trying to keep themselves upright or in a certain position to be able to feed. Because when that happens, as already mentioned, these kids don't have much energy to begin with, so they're probably burning all their energy trying to get in position to feed, and then they're not going to have much energy left for the actual feeding. So sometimes having the baby lie on their side and you lying on the side with the baby feeding them can work and can allow them to conserve energy for posture and really focus on the oral process of feeding. If a child has to pull too hard to get the milk or the formula out of the bottle, that can be exhausting for them. So having the right choice of nipple on the bottle that allows them to not get too much fluid in the oral cavity to swallow, but allows them to get an appropriate amount out of the bottle with as little energy as is possible. And also having as high calorie formula as is possible. And maybe these babies also are going to need supplemental oxygen during the feeding. And this is the tube that goes under their nose, that delivers the extra oxygen because they're going to be breathing less as they feed. For a child with a weak suck, so they don't have the muscular strength to have a strong oral seal and really get a strong pull on that bottle, then once again, having the appropriate nipple on the bottle that is going to allow the child to take an appropriate amount of formula without exhausting themselves. having the child positioned most effectively. And also you can have your hand under the child's mandible, sort of cupping the mandible, and your fingers can come up around his cheeks and help him form a labial seal around the nipple or the bottle. And if their suck reflex is too weak, you may have to back up and work on strengthening the non-nutritive suck, and then move back into the PO intake with the nutritive sucking pattern. And oftentimes what you'll see is that baby is going to stop pulling on the bottle. If you tug on the bottle a little bit like you're pulling it out of their mouth, that will give additional resistance for them to be able to suck and create a negative pressure within the oral cavity to get a bolus out of the bottle. Some babies, as they're feeding, they're going to have excessive mandibular movement. It's sort of like a munching behavior. And there are some forms of bottles and nipples that rather encourage this. For these babies, you want to position them into something of a chin tuck posture as you're feeding them, because their mandible can only move so much when their head is tucked a little bit. And then also, once again, having your hand up under the mandible so you could support it and you can restrict extra movement. For those babies that really struggle to form an appropriate anterior seal around the bottle, you need to be sure that that baby is appropriately aroused. You need to be sure that they're appropriately stimulated orally, and this could be something as simple as stroking their lips or tapping their lips, and that'll sort of begin the elicitation of the infantile reflexes of feeding. It will prime the brainstem to start getting all those reflexes in order that is going to allow the child to begin and then successfully feed. You could go in with a gloved hand, providing oral stimulation to the hard palate or the tongue, or when you're putting the nipple in the baby's mouth, trying to push down on the tongue slightly with the nipple, or trying to push up on the hard palate with the nipple of the bottle. Sort of cue that baby to understand where that thing is. Once again, cupping the mandible, bringing your fingers around to the sides of the child's mouth and sort of helping them form a lateral seal with their sucking pads on the bottle. And this sort of goes for those children that have difficulty initiating the suck reflex. Pushing down with the nipple on the tongue, pushing up on the hard palate with the nipple, positioning the baby appropriately, assisting the baby with controlling the mandible. Just basically putting that baby in as optimal as position as possible to take the feed, and then stimulating that baby orally as successfully as much as possible to cue the elicitation of the sucking reflex. If the baby is showing a level of agitation and is showing some tremors, then calming techniques such as swaddling the child, lowering the degree of light in the room, talking to the child or not talking to the child, whichever they feel more relaxed by, probably rocking the child or doing something slow and rhythmic. I had a daughter that was very colicky, and I spent about 6 months of my life every night, holding her, sitting on top of the clothes dryer as it cycled. And that would put her to sleep, but nothing else would. So we'd swaddle her super tight. I'd be rocking her, sitting on that machine with it making that rhythmic noise, blocking out lots of other noise with dimmed lighting. Munching behavior, I've already addressed this. For kids that are having some abnormal lingual movement, such as a retracted tongue or too much of an elevated tongue as they're trying to feed, you're probably going to have to back up and work on the non-nutritive suck pattern. You want to stimulate them orally as much as is possible. And once again, have them in as optimal a position to take the food as you can get them. So it's the cupping of the tongue during the feed that allows the baby to keep the liquid bolus and really facilitate it posteriorly. So if the child is not doing that appropriately, then basically you're going to be working to stimulate the tongue to make it more active, also providing appropriate support to the mandible. For those babies that have abnormal tongue protrusion during a feed, then you might have to back up and work on non-nutritive suck. You might want to have a larger nipple on the bottle that is going to restrict their tongue more from being protruded. If a baby is sucking too much without stopping to breathe appropriately every once in a while, then you're going to have to remove the bottle from the baby's mouth every 3 to 5 patterns of suck swallow, cueing the child to breathe. Or you could just bring the baby up a little bit, tilting the liquid in the bottle away from the nipple, cueing the baby to stop taking fluid from the nipple and to breathe. You could use a slower flowing nipple, or you could thicken the liquids and thicken the formula. And oftentimes we thicken the formula with rice cereal. But once again, if you're going to thicken the formula or if you're going to use a slower flow, you have to be sure that that baby is not so weak that he can't pull the appropriate bolus, thickened bolus, out of the nipple. And you got to be sure that the flow is not so slow that he is overworking to get the formula out of the nipple. And the preemies tend to be more predisposed to what's called feeding-induced apnea, which is what we're talking about, not taking enough breaths as they're feeding. They tend to be more predisposed towards this at the beginning of a feeding, and that makes sense because they're going to be more hungry. Once they've gotten some formula in them, towards the middle or the end of the feed, they start getting more relaxed. They start breathing more, sucking less. If you have a baby that is breathing too much and is not taking enough formula, then you want to be certain of that baby's respiratory status. You want to be certain that this baby, their swallowing gets watched on a modified barium swallow. You want to be sure that they are given plenty of breaks, that they're allowed to breathe appropriately. And also maybe they're going to benefit from supplemental oxygen during their feeding to keep their O2 sat up. And maybe that will allow them to breathe less and take more food. Oftentimes what you're going to see is not a lack of a sucking behavior, but a very disorganized sucking pattern. And as I've mentioned, to suck, hold the bolus appropriately, breathe, and then swallow at the right point in respiration, and keep everything straight and keep from aspirating and keep from the oral cavity getting too full takes a lot of coordination. So a lot of premature babies struggle with this. To help them, to increase the odds of them being able to have a more coordinated swallow, you want to swaddle the infant to really restrict their movement so he can't be doing lots of other things, but he's motorically focused on the feed. You want to reduce stimulation. You want to reduce the light and the noise in the room. You want there to be soothing, rhythmic music. You want to introduce the formula a little bit at a time. Maybe prime the baby before the feed by putting some on his pacifier and allowing him to suck on the pacifier, eliciting that non-nutritive suck pattern, which is going to hopefully prime a more coordinated nutritive suck pattern. And if that baby is struggling to control the bolus, then obviously allowing less of the bolus into the oral cavity at a time, so reducing the flow rate. So that means a different nipple on the bottle, perhaps thickening the liquids a bit with some rice cereal. Allowing the baby to take a bolus into the oral cavity, but then removing the bottle, or bringing the baby up like this, shifting the liquid in the bottle away from the nipple so that they can't take more in, sort of cueing the baby to focus on the bolus that they have in their mouth. In this population of premature infants, you're often going to see that they are highly fatigued and lethargic during their meals. And that is oftentimes a reflection of the amount of energy that they have to expend just to successfully breathe. So if that baby is easily fatigued, you want to start with smaller amounts. And if the baby cannot take enough food by mouth, you want to be sure that that baby has a feeding tube and is getting non-oral feedings as well. And it's important while the baby is getting non-oral feedings that someone is working with them to elicit the non-nutritive suck pattern that is giving them oral stimulation, so that the baby may not be actively swallowing during their meal, but is associating oral stimulation and sucking with the bodily sensations of being fed. If you have a premature baby that has a delayed swallow reflex with some accompanying aspiration, then you want to stimulate them orally as much as possible prior to the feed to increase the likelihood of that swallow reflex being primed and being cued in a timely manner. So allowing them to suck on a frozen pacifier. To create a frozen pacifier, you take the pacifier and you drill in through the back of the passy, not the front, and then so that you can fill the nipple with water, freeze the pacifier, and now that baby is going to be able to suck on the nipple of that pacifier with the ice in the middle. And you don't want to put the hole in the part of the pacifier that goes into the baby's mouth, because you don't want that ice melting and that water getting into the baby's mouth. And then once they've been orally stimulating, probably using a very cold formula or a thicker formula that they can control more readily, that's going to move more slowly and be less likely to get into the airway. before the swallow reflex is cued. You want to limit the size of the bolus, obviously, and you want to limit the amount of formula that that baby can have in their mouth at a time. So he'd take a pull off of the bottle, and he'd remove the bottle, cueing him to swallow safely, hopefully. And also, obviously, if this child is at risk of aspiration, then having him in the most optimal position to reduce that aspiration, which would be the baby sitting upright with something of a chin tuck position. You may have to have an angled bottle so that you could feed the baby appropriately with the baby in the chin tuck position. You want to be sure that the baby is staying alert throughout their feed if they're at risk of aspiration. Many babies will naturally fall asleep towards the end of their feed, and you wouldn't want this in a baby that has a delayed swallow that is going to put them at risk for aspiration.